Well, welcome everyone to Ask the Mito Doc. We're excited to have you all here. I'm going to give you a little rundown of what's going to happen today so you know what to expect. We will get started. I'll do very brief introductions of our clinicians that are here. And then I have a slate of about 6 pre-submitted questions. I will do pre-submitted question and then accept a question from the audience. If you have a question, you will need to raise your hand and one of our mic runners will join you. And you can't ask your question without using the mic because it will not be recorded and we won't be able to hear it. So that's a little housekeeping. We'll try to get it to as many questions as possible. I feel like we are starting on time, so we have a good chance of making that happen. So I will now introduce myself. I'm the moderator. My name is Margaret Moore, and I'm the Associate Director of Support and Education for the UMDF. Most of you, if you don't know me, you've received an email from me, so you probably do know me. Our panelists today are Dr. Bruce Cohen from Akron Children's Hospital, Ganesh, Dr. Jaya Ganesh from the Icahn School of Medicine at Mount Sinai, Dr. Sharma from Children's Hospital of Philadelphia, Jennifer Wang of the University of, they did not fix my slides. We've got another one that I want to make sure I give you the right information on. Hang on. We had some changes to our slate today. Jennifer Yang from the University of California at San Diego, and Matthew Ginsberg, MD from Akron Children's Hospital. So this question was pre-submitted, but interestingly, it is a question that if I had more time, I would have changed it a little bit because it was a question I had. I was unable to attend the clinical trial updates session today. This question says, what emerging treatment do you feel holds the most promise for patients with mitochondrial disease? I'd like you to address that question, but also think about what you heard today at the clinical trial updates. I will leave it up to you all to decide who gets to go first on this one. I think you probably all have thoughts.
Okay. Matt,
I'm going first. All right.
You're up first.
All right, fine. So I guess I'm going to answer it in the long-term vision. So I do think that for any Mendelian disorder, single gene disorders, especially if they're nuclear encoded, that strategies that replace a missing gene like gene therapy or gene editing are probably the most, I guess, exciting to me personally, because they have the promise of sort of permanently restoring the fundamental error that's occurred that's leading to all of the follow-on issues with the mitochondria or symptoms. So that's probably my long-term vision for what's going to be the most promising in the future. And I was at the other doc is in session during the clinical trials update this morning, so I actually missed most
So you
of
missed it too.
Yes.
So maybe I'll tackle, I got a problem with the word promise. It's a marketing tool. It's not science. And I've been involved in clinical trials since the late 1980s. Those trials involved treatments for cancer, specifically brain tumors. I moved over to the mitochondrial space about 15 years ago because that's when clinical trials started opening up for mitochondrial disease. So until a drug's on the market and in use for 3 years, I'm really hesitant to put a word like promise behind it. Even the most effective drugs have side effects or there can be bumps in the road. Having said that, the second issue with the question as it's written, it's a great question, but it shouldn't be mitochondrial disease, it should be mitochondrial diseases. There's a drug in front of the FDA right now, we heard about it this morning, for the treatment of TK2 disease. That's one of several hundred mitochondrial diseases. That drug looks like it's incredibly effective at eliminating or reversing at least some of the motor symptoms of TK2. So we're not talking about all mitochondrial diseases, but just one mitochondrial disease with that drug for TK2. So I think we're going to start seeing many, and that could be 5, it could be 50 treatments over the next 10 years for mitochondrial diseases. There's a lot of exciting stuff out there, but until we do the clinical trials, we're not going to know the answer. And until the FDA approves it, we're not going to be able to get those medications into our patients.
I'm just going to add one more thing. Gene therapy definitely is the vision. A lot of our experience in rare disease or in pediatric and across the lifespan, a lot of our recent experiences with gene therapy and disease-modifying therapies in the neuromuscular world with SMA and Duchenne muscular dystrophy. So there's a nice synergy between gene therapy as well as disease-modifying therapy that they can work together. Because for, usually in gene therapy, you want to be able to screen early and get it before there is downstream consequence of the gene. But we have patients who are already living with the disease for a while. So we need to not forget that, we do need to think about disease-modifying therapy that can address a different phase of and converging symptoms from various causes of primary mitochondrial disease.
I'm just going to add that I was excited to hear about gene editing being applicable to mitochondrial DNA. That was one of the basic science talks earlier in the conference. We recently had a child with a metabolic disease who was successfully treated with gene therapy that was personalized to him, and that was amongst a lot of different news articles in the country. So I've had a lot of patients come in and ask, hey, why can't you do this for me and my genetic defect? And that becomes a much harder question to answer for our patients who have anti-DNA diseases. So it was exciting to learn what people are doing in terms of gene editing with mitochondrial DNA.
All right, go ahead.
I also missed the sessions because I was at the Mito doc, but I recently came off another parent meeting, and the discussions was when you talk about gene therapy, it's AAV, lentiviral-mediated mRNA, antisense oligonucleotide, gene editing, and gene editing using viruses or gene editing using lipid nanoparticles. So it is pretty broad when you think about those type of treatments. And mitochondrial disease is also very, very broad, and it's very heterogeneous, and then you have the spectrum from the very severe to the very mild. So I don't think it will be like a one treatment fits all or one fits all type of approach. It'll have to be individualized, but if I have to think of the one promising thing that I've heard in the past month, it is this LNP-mediated gene editing. It's actually coming to patients for some X-linked disorders. And when I heard about that, it's like one copy, and so why not the mitochondrial DNA? So something like that, I think, will be the way to go. And then for diseases like TK2, like Dr. Cohen mentioned, the nucleoside are doing extremely well. The results look promising.
Thank you. For those of you that just joined, and actually for the audience as a whole, the way it's going to work today is I'm going to do one question on the screen and then take one question from the audience until we deplete these, and then we'll take all of your questions. So if you have a question, please raise your hand and we'll send the mic runner over. Any questions yet? Okay, I know you've been storing them up. Don't be shy. If anyone has anything, though, after the next one, please raise your hand. Okay, this one would probably be for the geneticists in the group, or really anyone. I had genetic testing years ago. The results were inconclusive. Is it worth it to do it again?
Depends on what it is, right? So in general nowadays, even if you've had pretty broad evaluation like an exome or a genome, and you had a variant of unknown significance or inconclusive, we generally recommend waiting about 2 years for reanalysis. Now there's newer technology in terms of sequencing with long read sequencing. Usually right now it's short-term sequencing. don't need to know all the details. It's just a little, even a better look at the genome. So now there are some services where they version a 2.0 version. So if you have highly suspected mitochondrial disease with inconclusive genetic testing, you could ask for a newer technology or a newer methodology for that.
Would you say there's a time frame, like if someone had genetic testing 10 years ago, should they start over, kind of?
So if they had like single gene testing or a panel, and now we know we've described so many more genes, and there's clearly symptoms, and there's clearly evidence of mitochondrial disease, we just don't have a molecular diagnosis yet, then I would recommend going to a broader evaluation with an exome or genome, or mtDNA, depending on what the suspicion is.
I'll just add what I've learned from my genetic counselors who are much more savvy with kind of understanding what the platform used was for the genetic test, what company did it, and how they did it, depending on the year that was done and where they got genetic testing done. They might recommend it just from hey, we have a better platform, we have better ability to detect mutations compared to when this test was done.
I would sort of view genetic testing as like television sets. If you go to a television set made in 2005 and watch a football game, you can't see anything. The clarity with new genetic testing is incredibly impressive, but in 2028 it will look primitive to what it will be in 2028. So it's a question that be best asked of your doctor, genetic counselor, geneticist, neurologist, your Mito doc, if it's worthwhile now to step up and have repeat genetic testing. So I think the simple answer is you need to talk to your doctor, but yes.
Thank you. Any questions out there?
I'll actually add a little urgency to that, because I had a family who had a mitochondrial DNA mutation that was running in the mom. The first son was affected, but she had genetic testing 12 years ago and nothing was picked up. And so she had another partner and now has another child with the same mitochondrial DNA mutation, now with Lee's syndrome. And so I think that, in those type of situations, I think if your genetic testing has been even 2 years, I agree with that, you really need to see a physician. And many genetic practices in the country support prenatal genetic counselors. So these are genetic counselors who are trained in reproductive genetics specifically, and they will be able to give you a good understanding of what has been done so far and what can be what's available. And they may be able to help refer you to a center that can handle additional testing. So it's always important to go to them, especially in a reproductive situation.
Well, that's super interesting. So a family that maybe got a result of nothing before has the potential to get something showing up today because of the improvements in technology. I've sort of heard of an add-on. What are the next steps in genetic testing technology? What do you think's coming?
Before I answer that, I just have one other comment, because Dr. Ying mentioned it, but in case anybody missed it, the reanalysis part is not totally trivial either, which is that even with the absolute best technology, be perfectly sequenced your genome, part of the limitation of current testing is our limitation in knowledge about how to interpret variants or changes in the DNA. And every few years that gets better. New variants are assessed, we have new information. So, we recently had a patient who was just reassessed, reanalyzed, and got a confirmed diagnosis that way, essentially. So, I also would say, to answer your question, I think we're just starting to use the long read sequencing a little bit more now and pick up some interesting things.
Can you tell me about that? I'm not sure I know what that is.
Normally with the sort of what was called next generation sequencing, the way that the technology works is that it chops up DNA into little bits that might just be 100 letters long. And that's really good for most of the things that we're checking for, but there are certain kinds of conditions, genetic conditions, that the technology just misses, just inherent to the fact that you're chopping up the DNA so small and having to align it to a reference. So these newer technologies, they can sequence much longer stretches of the DNA molecule, that very long string, and that allows you to catch some diagnoses that just where you either had to order separate tests for them before, or may have been just very difficult to diagnose previously.
Very interesting. Any audience questions yet? Okay. She's coming around with the microphone. We can't hear you unless we have it.
What interventions or advice would you have for a patient who gets elevated CK levels, rhabdomyolysis, but from just like everyday, like walking, like exercise has been completely taken out as an option, but just regular day to day still ends up with rhabdomyolysis and elevated CK levels? Like, what should working out look like?
Is this is there a genetic diagnosis? Oh, okay. Just confirming, it's a couple of other inborn error of metabolism that does that. Do you have-
I mean, if it is definitely a mitochondrial, it's a mitochondrial DNA mutation that's causing this rhabdomyolysis. It's kind of a little unusual. Usually, there are certain other diseases which give you that kind of episodicity. But what we have done for our patients across the board with rhabdomyolysis is address the diet adequately. So avoidance of fasting, do a complete dietary analysis, carbohydrate, fat, protein content, and then probably see if you're responsive to a higher carbohydrate or a carbohydrate snack before exercise. Sometimes medium chain fat can work, but again, with mitochondrial disease, you've got to be careful how you're tweaking it. So those are the avoidance of prolonged fasting, avoidance of certain medications. That is what we would recommend in mitochondrially mediated rhabdo.
Also, I mean, in general, maybe not specific to a rhabdo, but, a lot of exercise muscle pain, just staying really, really on top of hydration best you can. And instead of just water, sometimes like the actual electrolytes, like the powdered IV that you put, that basically tastes like Gatorade, but there's actually a little bit better concentration of that, or something like Pedialyte. And, if you don't have a lot of, if you can handle the fluids, just to really be on top of and pre-hydrate. And then work out, but more frequent breaks in between.
We work with a lot of younger patients who find it hard to regulate their activity, and they either land up in a crisis or unable to function for a few days. So that's something we encounter not infrequently, and we try to work with our physical therapist recommendations and stay in touch with their local physical therapist to develop a graded exercise program to understand where their tolerability is, how frequent breaks they need, what is the total duration of exercise they should be participating in, to make that a more sustainable activity from a day-to-day standpoint. And this is not just specific to rhabdo, but the fatigability that we see with a lot of our different mito diseases.
We sometimes also do just an emergency plan in the chart if an episode of severe rhabdo occurs. That way, if you're going to the ED, then you kind of know what to look for and what to do if it were to get that bad too.
Not any comments? We'll go on to the next question. My blood sugar is all over the place. What should a mito patient cover when going to the endocrinologist? How would you advise them to prepare for that kind of an appointment?
Well, the newest technology allows for continuous glucose monitoring, and I think a lot of the endocrinologists are going to say, your glucose is all over the place, let's find out really how all over the place it is. So I think that's the most important advancement in technology. I think the standard approach to a non-mitochondrial patient would probably translate, at least on first iteration of what the endocrinologist is going to do is going to probably, if the endocrinologist says we're going to work you up as if you were a non-Mito patient, I think that may get the answer as to how to approach the problem. And the other important point is for the endocrinologist to contact your Mito doc so that you can close the loop on what else may be going on.
The endocrine doctor will, probably ask a lot about diet too. So depending on how you're monitoring your blood sugar, knowing kind of at least roughly, in relation to meal times, it's going to be brought up. And then generally, how often you're eating, what types of food you're eating, and some more information about that. And then in general, at least for, I may not do it for super young age groups, but in general for, our mitochondrial disease clinic, we have some screening labs, and so there is some baseline labs. You can work with your either primary care doctor or a mitochondrial specific doctor that there's already some numbers ready for the endocrinologist when you go to that appointment. Presumably you do, but.
Yeah, again, the new technology, I have a patient who's 10 years old with Pearson syndrome, which is a mitochondrial DNA deletion disorder, whose glucose was all over the place, and everything the endocrinologist and I were doing didn't help. But with new technology in terms of insulin pumps and insulin sensors, the blood sugars are now in decent control.
In our clinic, we try to partner with endocrinologists who have an interest in mitochondrial disease, have experience with those patients, can give you some feedback in terms of how they have treated some other patients with the same gene, or what medications worked, what didn't. So that always helps, I think, families, and they feel more comfortable seeing a provider who is more familiar with metabolic or mitochondrial diabetes. So we try our best to partner with those providers, both from a pediatric and an adult standpoint.
Some of the questions we as Mito docs get from endocrinologists is about what drug to use, and the knee jerk is certain drugs like metformin are not the best to reach out for in patients with mitochondrial disease, with lactic acidosis, etc. But as we heard on the first day from one of a senior endocrinologist, it's not always the case. There may be some patients who do okay with metformin, and it's a pretty good drug for the overall management of diabetes. And then there are some of the newer drugs like the GLP-1 agonists and the SGL2 inhibitors. They may not be the best to reach out to for mitochondrial patients as a first line, even if there is another comorbidity like high body mass index and so on. So I think it's a discussion, and it has to be personalized to each patient and the age of the patient. But the CGM and the insulin pumps are definitely making a huge difference in our management.
Just to add on to the metformin story, metformin and drugs like metformin historically have been associated with elevated lactic acidosis. But I've had plenty of adult patients with mitochondrial disease, including me loss, come to me already on metformin. In other words, the metformin had been started 5 or 10 years earlier, and they didn't have any adverse events to the metformin. So I understand the literature says watch out, but I agree that it may be safe in select patients. One of the advantages of metformin, other than the fact that it works in a subset of patients, is that it is incredibly inexpensive. In fact, most insurance plans will give it to you for free because it's cheaper to give you that drug for free than to take care of the complications of diabetes.
And the general rule is to go low and go slow. So, there's nothing that's super contraindicated. So just knowing that, in Mito patients, there may be more sensitivity in general, just to, do a, slower titration and just kind of see.
Something that's kind of struck me in this conversation and the topics that we've covered before is that you've mentioned diet multiple times. Is there any sort of rule that a patient with a mitochondrial disease might consider in terms of scheduling with a nutritionist? Or is that something that you recommend to your patients once a year? How does that work?
Yes, absolutely. We have a nutritionist who works with us, especially for patients who suffer from significant GI symptoms. And what we tend to see a lot of is gastroparesis, low motility, bloating, and that really impacts their lifestyle. And we have many children who are unable to tolerate their feeds, and it affects their growth, it affects their ability to gain weight and their development. So yes, absolutely. We involve nutrition as part of their care from the very beginning, or as soon as we can.
Yeah, I'm trained as a metabolic physician, so in my practice, the mitochondrial clinic has always been within the metabolic program, and I work with 4 dietitians. And so diet plays a huge role, particularly in children with mitochondrial disease, and I'm pretty sure even in adults, but that's much more difficult to control. And one of the things we've done is we've changed formula to for children to have a little bit more MCT than long chain fat. That seems to be better tolerated. Some of the protein composition is also changed to make it a little bit more elemental in some situations, especially when they've had an admission for an acute illness and they are still recovering. So in those stages, we do put in G-tubes when necessary, especially when there is a failure to thrive. And many of these children get a small volume of feed overnight, because prolonged starvation, particularly in the setting of an intercurrent illness, I think they fall apart even more than on a day when they are not otherwise ill. And so a G-tube helps tide them over and maintain their nutritional requirements. And we'll send them home with an emergency letter that if there is poor PO tolerance, if they are in any way catabolic, to get them into the hospital and start IV fluids and IV hydration. And we also have a very low threshold for starting parenteral nutrition if they are going to be fasting for a long time and they're admitted with intercurrent illness. So we do pay a lot of attention to the diet, and I think children actually have done well, and many adults too, with that kind of modifications.
I'm ready to accept another question from the audience. I see gentleman in the middle.
Hi, my question is about dosing of L-arginine and citrulline. I guess the function of it, the purpose of it is, and then the dosing. I assume that it has something to do with stabilizing blood vessels and sort of prophylaxing against seizure-like episodes, and my daughter has MELAS. But so the dosing is, the question is that scientifically based, or is that just a shotgun approach that you're doing? And are you trying to target like at least a minimal trough level sometime during the day with these high doses 3 times a day? And would it make more sense to do it 6 times a day?
So both arginine and citrulline are intermediates in a metabolic pathway called the urea cycle, which is active in all of us and helps us get rid of the ammonia from the protein and amino acids that we metabolize. And the dose of both arginine and citrulline is really based on what we use in patients with urea cycle defects. So that was the starting point. So the bigger question, and I think at this meeting there was a lot of discussion as to whether you use this at all. The underlying principle is the vasodilative properties of arginine, and citrulline is a few amino acid metabolites before this production of arginine, and it's much smaller, so it crosses the mitochondrial membrane much more easily than arginine. So that's why citrulline was used, and Dr. Scalia is doing a study studying the effects of citrulline in patients with MELAS. But the bigger question is, what exactly are they doing in a patient with MELAS? So the old literature and the traditional wisdom is that they help in cerebral perfusion in these patients with MELAS. But now the European group has been a bit more vocal in saying that we are not sure, and they are not using arginine or citrulline in their cohort of patients. And so it's very hard for us to compare head to head the experience of theirs and ours. We believe it from a metabolic standpoint, we think it makes sense. So that's something that I think the MMS is probably going to look into in the future. But for the moment, I think all of us usually in the States are comfortable using arginine, and I've increasingly started using citrulline in the patients. And my dosing is based on the urea cycle dosing. And Dr. Scalia had some information from preliminary clinical data that a slightly higher dose of citrulline is tolerated with benefit in this. So it's still under review.
Yeah, I mean, his data from his citrulline study is they're adult patients. So in kids, it's usually, I think as low as 150 milligrams per kilo per day divided 3 times a day, up to 300 or 500 milligrams per kilo per day divided 3 times. It's kind of the oral dosing equivalent of the IV dosing of arginine that we give if you come in with an acute stroke. The reason there's not a big difference if you do 3 times a day versus 6 times a day. It's just giving something 6 times a day is generally not something that someone wants to do. So, so that's why we usually stick to 3 times a day. The use of IV arginine for an acute stroke in MELAS is going to remain in the upcoming statement still for our US MMS statement for treatment of mitochondrial disease. It's going to be a little bit different than the European group. But in their defense, though, their point is that patients who present with stroke-like episodes in MELAS may not be having a metabolic stroke per se. You can have focal neurological symptoms that looks like a stroke, but actually it's due to a focal seizure. So they were pushing for a earlier evaluation for seizure for that moment. And it doesn't, arginine, citrulline are not, directly anti-seizure medication. So there should still be a careful consideration looking at EEG monitoring if you present with a stroke-like episode.
We do the same thing where we definitely use IV arginine for acute metabolic strokes and MELAS and other Mito disease patients. And we use oral arginine as part of their day-to-day supplementation when they've had stroke-like episodes. We will look at their plasma amino acids and their levels to help titrate the dose. And then for citrulline, I wanted to add, we've started looking at it more. We found that our DATP6 patients, for example, very often are low on citrulline levels, and we do supplement those, and we titrate the dose with sort of subsequent checks and monitoring their levels on plasma amino acids.
Since I have the mic, if I can ask one more question quickly. One of the biggest impacts on my daughter's life is the frequent headaches that she has, and I don't know how to treat that. She will take Motrin, and sometimes a little bit of Ativan might help her relax, and maybe she'll get some sleep, but it's quite often, and I just don't know what to do.
Was the question about frequent headaches?
Yeah, what is
Yep.
any recommendation on the best therapeutic approach to that?
So I'll start with that. The first thing is that overuse of ibuprofen or Tylenol or any of the typical over-the-counter headache medications can cause what's called a rebound headache. I think the most recent recommendation is that if you're using those more than twice a week, you need to consider cutting them back to at most twice a week so that you don't get the rebound headache. I also feel very strongly that in a mitochondrial patient with chronic headaches, that a sleep study ought to be done, because one of the causes of headaches is sleep apnea or low ventilation during sleep, just to make sure that there's not sleep apnea going on. In terms of how to treat the headache, I use a lot of vitamin B2 in my practice, and B2 and magnesium, which is actually a combination that's very natural and recommended by the European doctors. So I think I'll end the comment there and let others pitch in.
I mean, I think if they're migraine headaches, there are quite a lot of options for treatment, and it's usually an individualized discussion, so it might depend on what other medical symptoms you have, what other medications you're already on, but there are usually a number of options to discuss. And also some of the typical lifestyle things that we do for all persons who have migraines, including things like hydration, regulating sleep, managing stress, a bunch of those kinds of things, biofeedback, there are devices, so there are a lot of options.
I've had some young adult patients who, with meal loss, who did really well on the newer class of migraine medications. So like none of them are really off the table. The CGRP inhibitors, that's worked well for them. Yeah, I would be careful of too much use of ibuprofen and Tylenol for that. There's also some approved non-pharmacological kind of neuromodulatory type of devices that can help with migraine headaches as well.
I've definitely had patients who don't want to add more medications to their regimen, and things like the wearable devices, which you could wear on your forehead or your arm, that works on the principle of like an electromagnetic pulse that interrupts the pain signal, and that's how it gives you relief. You're able to use it for both preventing and treating headaches acutely, and they like being able to use that since it doesn't have any adverse effects and is not going to interact with their other medications. And along those same lines, the non-medication options also include things like acupuncture, for example, that has a lot of good evidence in headache control.
Okay, I'm going to go on to the next question. This is one I didn't understand, so that's why I included it. Is PRP platelet-rich plasma used in mitochondrial disease?
Not
Not
yet,
standard.
but there is I heard one of Dr. Hirano's trainees present, not at this meeting, but recently, about studying this. And the reason is platelets are very rich in mitochondria.
Do you mind giving a little overview of what it is? Because I even didn't know what it was. I included it because I thought it would give us a conversation.
Was it the Gateway
was
presentation?
about the
Yeah,
Gateway
it was
presentation.
very cool science. I cannot give
So-
you more info.
Yeah, I don't want to misspeak, but not to keep you on the edge, it's the platelets are, part of the blood, the red blood cells, white blood cells, and platelets. And the platelets actually are rich in mitochondria. And the idea is, if you have a patient with mitochondrial disease, with mutant mitochondria, the mitochondrial DNA mutation itself triggers a whole cascade of bad effects. And so delivering normal platelets with normal mitochondria will alleviate the phenotype, particularly maybe a stroke-like episode or something like that. So she had some very good data, and it was a brief presentation, and I wanted to listen to it, but I missed it at the session. So Dr. Hirano will be able to tell you more, and it sounded very promising.
Thank you. That helps me understand that it is something that is maybe an emerging therapy.
Yeah.
Very excited. I want to take a question from the audience. I saw right in the middle here, next to the turquoise shirt. There you go, first.
Hi. So I have a question kind of related to gene editing. Our son has PPA2 deficiency, which is nuclear DNA based. And I guess I don't really understand all the science that goes into gene editing. But in our scenario, we do know of some researchers that are working on gene editing for the specific mutation in Europe right now. But what we don't understand is there's different variants within it, and they're working on a variant that is not our son's. So I guess from your expertise or knowledge, once they develop, say they are successful with that gene mutation editing, if they're able to fix it for one variant, would it then technically work for all the other variants of the same mutation, or would they have to sit there and develop? I'm sure there's thousands of variants for every disease, so I just don't know if you have any more info on how that works.
Matt, why don't you take it?
I don't want to misspeak. I'm not a basic scientist, but in general, with some of the gene editing technology is They often use what's called a guide RNA, which is like a homing missile. It really guides the machinery of the therapy to a very, very specific variant or change in the DNA. And so it may be very specific to that individual variant. So it might require a different guide RNA to address a different variant that maybe your son has. It really depends though on the details of how the therapy is working, whether you're just trying to knock down a gene or replace, correct it if it's changed. So there are some nuances, I think, depending on what the strategy is. And then, of course, once you've developed a therapy that works for one variant, that may, at least grease the wheels in terms of developing it for other variants.
Again, I will plead ignorance, but the only thing I can say is that there is a gene editing protocol for a condition called OTC deficiency, urea cycle. And I think that technology is what we say mutation agnostic. So you have to have a mutation in that OTC gene, but it doesn't matter where in the gene the mutation is. So I think we'll have to find out what the researchers in Europe are doing with this particular condition. So different gene editing platforms are coming up, we don't know. But for the one that I know, it's mutation agnostic. So I don't think it'll be like specific variant based, as long as there is a mutation in that gene, because otherwise it's not possible to treat patients.
I'll just add, from what I understand, another challenge is how you deliver the therapy to the patient and how do you get it to the organs that are affected by that specific disease. And I think from a neurology standpoint, trying to get a gene therapy into the brain is a technically challenging issue. So either you develop a product that you could potentially give intravenously and it would cross the blood-brain barrier and get into the brain, that would be the ideal situation, but that's a very technically difficult thing to do. There are approaches of neurosurgical approaches where they would directly deliver the gene therapy into the brain. And then it becomes a big question of what part of the brain would you inject, because you're limited to a one-time approach in those situations. And would it go to all the different parts of the brain that you want to go to? So all of those are some very logistical challenges that need to be talked about, need to be thought about with every specific genetic disease.
Oh, we got another hand. I think I saw somebody in the back raise their hand with the plaid shirt.
So our son has a WARS2 deficiency, and one of the big issues that we've been dealing with is his chorea or dystonia. And we were just wondering, like, what treatments have you used in your clinics to help with that? And because what we've had so far has not been really successful.
I'll just say I think it can be very difficult to treat. So sometimes it's hard to achieve something that's really satisfying without causing too many side effects. I would say a lot of the time we often start with a type of medicine that's in the family called benzodiazepine, things like Klonopin, clonazepam, and other related medicines like that. But there are other ones that we try also, but sometimes it's just difficult.
Dystonia and chorea are also, I know they go hand in hand quite a bit, but sometimes when we pick the class of movement, the movement to class of drugs to target, the movement in question is the one that is either more predominant or causing the most issues. So there are strategies we do for dystonic posturing, dystonic movements versus chorea. Chorea is notoriously really difficult to treat, but sometimes the tetrabenazine class can help too.
So the only thing I will add to that is, yes, we refer them to neurologists to manage the dystonia and chorea symptomatically. But there has been some interest in, if it's an RS2 or a NARS2, a tRNA synthetase mutation, sometimes giving a much higher, intake of that particular amino acid for which that synthesis works um, has been shown to be beneficial in the experimental, models. And so there are some physicians, I think Rita Horvath, if you can follow her papers, she has some good data on, trying this out, giving more amino acid supplementation to these children. And so we've tried that, but again, we've not been really successful getting these amino acids and getting them to tolerate what's the dose and how severe the disease is. Generally, it's been very frustrating experience for the most part. But when there is basal ganglia involvement, some of us have also tried to do a lot more biotin, riboflavin, because those cofactors are important for, mitochondrial function. So we've used those supplements in addition, but it's generally been symptomatic.
Just to add to that, I've got a patient with bad dystonia and chorea, and been taking care of this patient for 20 some odd years. And for whatever reason, tetrabenazine has been helpful, and gabapentin, which is not classically listed as a drug used to treat it, has been helpful. And we've tried dose reduction of those, and it hasn't worked out well. And when the problem gets worse, we bump up the dose and the problem gets better. Then we go back to the baseline dosing. So I'm pretty sure those drugs work in this patient, although you won't find that in the textbook anymore. You won't find that in the textbook.
Any other comments? Howard here in front. We'll get you next.
Real quick question. I heard about this morning. What do you know about research that's being done in Europe to use sildenafil to treat mitochondrial diseases?
I understand that researchers they have used it and talked about using it in the MT-ATP6 and MT-ATP8 patients. They think about, from what I understand, they think about its benefits in the vasodilatory effect that we kind of think with arginine, for example. And I know that they are planning to expand the trial of that medication to Lee syndrome in general to understand if that will impact the clinical symptoms in a positive manner. But I believe that's still in a planning stage.
So my question, my two of my three boys have RMND1 gene mutation, COXPD11, one stage 3 kidney failure, the other one stage 2. So I guess if the mitochondria or their disease is progressive, if they get a kidney transplant, won't they still have the kidney disease? Or like, what would happen? Does that make sense? Won't the mitochondria still keep damaging that organ?
There is a very nice paper from, I think it came from the UK a few years ago, it's almost like 7-8 years ago, where there is a cohort of RMND1 patients who had a renal transplant. And I think the outcome really depends on the degree of multi-organ involvement in these patients. We in our group actually our paper is under review. We transplanted 2 patients with Pearson Cohen phenotype, and then a 3rd patient from Baylor as well. And post-transplant, the mitochondrial disease, doesn't go away. But if the organ involvement is the kidney and the patient is in renal failure and with a lot of electrolyte imbalances and then fluid overload and all of that, the response was stunning to the renal transplant. They tolerated the procedure very well, extubated within the typical time frame, and were able to be discharged. There was one with post-transplant complications, but that's common in any renal transplant. So the thrust of that paper's argument was that just because it's mitochondrial disease, please do not consider a solid organ transplant. If that organ is the one that's causing the most problems, fixing that symptom is going to make the quality of life a lot better for that patient.
Okay, and so if they're not very good eaters and drinkers, before having a transplant, would it be a good idea to go ahead and have a G-tube for them?
Yeah, I think that that will be an individual decision that
Right.
your team will make, but yes.
Any other questions in the audience? Oh, right behind you.
Actually, I keep hearing the term mito-doc, and we're in the area where we're at, we don't have any mito specialists really. What would you define a mito-doc as? Would it be like a neurologic person, a neurogeneticist, or who would be the best person to fit that overall position? We start looking.
Where are you from? What part of
Alabama.
the country? Alabama. Sometimes it might be hard just in a particular region to find somebody who's an expert just in mito, but there might be a geneticist or a neurologist nearby who has some knowledge about it. And then some folks will maybe travel occasionally to a mito center that's closest to them for occasional care and then partner with local team. And sometimes that can be helpful. So sometimes you might just go once a year or something like that to the Mito Center and then have a coordinated care with your local neurologist and other specialists that are in touch with them.
Okay, yeah, that's about what we've been having to do. So one other question. I come across this, it was urolithin, urolithin. It claims about a 10% increase in cellular energy through the mitochondrial DNA. I didn't know if I was going to add that to his mito cocktail. I don't know if y'all have heard of that or if any of you are actually using that in the cocktail.
What was the second one? Oh, that one? I've heard of it. I think most of the study is from one center. I think it's Sweden, and from Europe. I think they actually might be doing a larger study right now looking at it, I think by the same group. So I think it's not on all of our typical starting off Mito cocktail. I've had a couple patients ask me about it, and I only had the 2 papers to go off of, really. And I think we've had them try. I don't think anybody's come back to me telling me it's been a miracle cofactor. I think in general, when you're looking at using cofactors and supplements, as you know, a lot of these are not covered by insurance. So, do have a careful discussion about weighing the pros and cons and what would that mean financially for you, to give it to try, a new cofactor.
He's been on it for about 2 months now. We haven't seen much improvement.
Yeah,
So.
I have not, counting on one hand, a couple of patients who have tried it on their own, and I told them, it didn't seem like it was super toxic, but I usually just, if you're gonna try something, do the 2 to 3 months, and honestly, if it's not making a big difference for you, this just may, it just may not be a thing that you wanna keep in your daily supplement regimen.
It's on? Oh. We're kind of in the same area. We're also in Alabama. It's just like
Where
right-
in Alabama are you all from?
So I'm from Madison, and I know they're from Grant, so in
Oh, okay.
Huntsville. So
I trained at UAB, so.
Oh, hi. My son has MTDND5. Okay, 13514AG. It's rare. I understand. We go to Children's Hospital of Birmingham for all his care. We do have a great. We're one of the lucky ones. We do have a great neurogeneticist there, Dr. Amita Anant, and she's great. She's working with us. Any questions that we have, she works with us. The reason is my son had a stroke, and it kind of put him down a little bit, and so we're doing speech therapy, physical therapy, and everything. Long story short, I had a conversation with the nutritionist the other day. She was asking a lot of questions because my son usually works out, so his diet is mostly protein intake and everything, but because of the stroke, it's kind of lessened and he's lost weight. So we were kind of concerned. I was concerned, right, of what else can I do or he can do to kind of make sure that his weight doesn't really drastically decline, because that is kind of bad for his mitochondria. How can we, as family, ask questions? Like, how do we frame it to explain it to the nutritionist, for example? I feel like I'm partially educating a lot of health people about his conditions, and I shouldn't be the one, the way I look at it. I'm not the expert at it. I know I'm going to misspoke, and I'm speaking on behalf of my son. So a lot of emotions are involved in it as well, right, naturally. But I was trying to come across to the nutritionist that, yes, I know, protein is good, carbs is good, and we have to look out for the carbs because of the sugar, because sugar is not good. What's the most effective way, or what are your experience has been of effective communication between family members and other health team, if that makes sense? Thanks.
Well, I'll start. You're not the first one to bring it up here, and you're not the first one, first patient to bring it up in clinic. That's incredibly challenging. I've been frustrated as someone who see these patients, and then, maybe not all of my clinical partners are as up to speed. I think there's a difference between someone who may not know everything about the disease at hand or a particular disorder at hand, but they're open to learning and gaining new knowledge to be able to actually take care of a group of disorders that they may not know of, versus someone who, has a more of a, who's more not open to that, and then, you end up having a really frustrating visit. So I think first and foremost, finding someone that you feel like you personally, on a personality level, work well, and even if there isn't a mito nutritionist, but maybe someone who has a personality that works better for you and your family, is at least kind of a first step and maybe an ask that you can have. But I think the point of us doing some of these sessions and doing a lot of the educational activities, through the UMDF, is to, broaden the scope of educating, not just our family and, families to advocate for themselves, but also, educate our peers about mitochondrial disease.
I agree with everything you say, but just to add to it, before I got to my current hospital, the patients who were at that hospital were being referred to me where I was. When I got to the hospital, there really hadn't been any experience with how to take care of a mitochondrial patient in the intensive care unit. But with communication, meaning I would go to the intensive care unit and have discussions with the intensive care doctors, pretty soon they became quite expert at how to take care of a mitochondrial patient in the intensive care unit. And they really don't need my help very much anymore, which is a great thing. So within institutions, I think communication works out pretty well, which is probably why there's 5 endocrinologists at Children's Hospital of Philadelphia that know how to take care of mitochondrial disease, because you're such a gigantic center. So, that's great. Within rural areas or outside major medical institutions or in small medical institutions, it becomes a difficult challenge. And there's this technology known as a telephone, could be augmented by actually Zoom, where 2 physicians can get on the phone together and generally within 5 minutes exchange enough information that they can, start the plan to take care of the patient. I recently referred a patient with a movement disorder with a mitochondrial disease to another institution because that movement disorder doctor thinks outside the box and is willing to go to bat for the patient. And she and I had a conversation about what a mitochondrial disease was. And we made an agreement that if she decided on a new therapy, she would pick up the phone and get this, call me to work out whether there was safety or dosing issues. So I think it all gets down to human communication. Now, you shouldn't be the one to have to tell your doctors to pick up a phone to call another doctor. Our first mitochondrial meeting that was run by the UMDF was in 2000, 25 years ago. And some of these questions are exactly the same as they were 25 years ago, this being the most prevalent question. It comes up every single Ask the Mito Doc. So you've shown what the weak point in medicine is.
The follow-up question that I have, and thank you for that, I appreciate that. Yesterday, I attended one of the sessions, and it was talking about stroke-like episodes, right, with patients and mitochondria. One thing is the emergency at the ER when you come in. You know, we have a protocol, for example, that we've gotten from the neurogeneticist that this is what you do, this is what condition he has, and all that, and then call us, do this, the protocol, right? So we come in, but it was presented yesterday that it's also good that if a patient comes in with a stroke-like episodes, regardless if they say that it's because of mitochondria, that it should be treated as a stroke patient as well, because there may be underlying other issues in there. How do you communicate that? Because sometimes also you say, we come in with the protocol and stuff, oh, this is what we're gonna do, right? Thus far, with all the ER visits that we've had, right? We only encountered one doctor that said, I don't care what condition he has. He is 16 years old, and we are seeing strokes on him. So he was airlifted to Birmingham. That was the only one. I even was the one that insisted, no, he has stroke-like episodes. This is because he has mitochondrial disease. But he was like, no, I'm the doctor. He's 16 years old. There shouldn't be a reason. But it's like, how do we constantly have to communicate? Don't overlook any other underlying issues when we come in, just because he has mitochondria, and we have a protocol. I think it still goes back to communication sometimes. And we're as detailed as we can as parents. We're the lucky ones. We're a little bit more detailed because of the job that we do in the private field. But I know not other families are like that.
I think it's a slightly difficult question to answer. So where you have the ability to have a quick MRI to confirm a stroke before taking action is the ideal situation. So for example, at the academic centers that we work at, for a pediatric patient presenting with stroke-like symptoms, we'll get an emergent, fast, unsedated MRI, and we would be able to identify if this is looking like an ischemic stroke, meaning that due to decreased blood supply, that's when we think about the traditional stroke therapies. I think it becomes difficult to treat it for a patient who's had an underlying known mitochondrial disease diagnosis, who's had prior stroke-like episodes. Those stroke-like episodes have presented similarly in a recurrent way. For them to be at a location where they might not be doing an MRI to confirm a stroke, where their practice might still be that they do a head CT, they make sure it's not a bleed, and if someone looks like they're having a stroke that corresponds to a specific blood vessel territory, they go ahead and give medications like thrombolytics that have a significant adverse effect profile. So that becomes a hard decision to make, as you want to make the best educated assessment and treatment plan. You don't want to expose them to the hyperacute stroke therapies that might be more harmful than helpful.
I'll add just one more small thing, which is that the protocols can't account for every possible sort of thing that can happen to a person, and so usually as part of that, it might just need to be to page the center, the Mito center that you're seen at, so that the ED physician who doesn't have experience can talk over that specific situation that's going on with the covering doctor from the Mito center. And sometimes that's just what's needed. to work through the details of that specific issue that you're having.
The other thing I was going to add is to tag on to what I said earlier about the use of arginine and the stroke-like episodes is maybe helpful to go through some of these events in more detail with your doctor and reviewing, what is the imaging finding at that time, if there is any concern that these might be seizures. I have some patients who come in with both. And sometimes a stroke-like episode, again, a focal or just one side of the body is affected can be part of a seizure. And my patients always have an emergency medication. Usually now we use the nose spray quite a bit. And so if we think actually it might be part of a seizure, something that you do, while you go to the hospital too, it's a concern for seizures that you kind of give the emergency medicine.
And in our practice, what we tell our patients is our patients are also coming from far and wide to the main center. So if you have a concern when you go to a local emergency room, please call the primary practice, your mitochondrial doctor. And if for me, there is a metabolic team behind me, so there is somebody on call all the time. And between the parent and the metabolic team and the ER provider that's actively taking care of the patient, we should be able to have a conversation as to what the symptoms are, what's getting better, because not every patient who's suspected to have a stroke is actually, so you don't have to go through the whole thing for everything, but there's always room for discussion and, moving forward in the correct way. But I also want to leave you with a positive note in that, 20 years ago, we were thinking, we had point mutation analysis, maybe we'll pick up a MELAS, we'll pick up a MORPH, we'll pick up a NARP, and none of the other mitochondrial diseases would be even identified. But now, every specialty, including cardiology, neurology, nephrology, are doing their own genetic testing. So genetic testing and genetic diagnosis are much more mainstream in the conscience of many physicians, including the emergency teams. And so when you say that this is a mitochondrial disease or this is a genetic disorder, they definitely have their, they're alert to the possibility that this is something that's not commonplace. It's not an infection or it's not an inflammation, and they are willing to partner with you and with the primary service. And of course, the support groups, people who've walked in your shoes will definitely have more information to share as to how they've negotiated these tough situations.
Anyone else with a question?
For patients with like Lee syndrome who have intractable epilepsy, you can end up on several different anti-seizure medicines all at the same time. In your perspective, how many anti-seizure medicines or anticonvulsive medicines are too many? And if you get on too many, what is the best way to go about reducing that load?
A panel of neurologists. I'm not sure if there's an upper limit, but usually the side effects will kind of limit the number of anti-seizure medications. I think Dr. Sinedo gave a really good talk yesterday about generally epilepsy management and mitochondrial disease. I think the success of seizure freedom with subsequent, adding subsequent anti-seizure medications just goes down, and I think that statistic holds true for mitochondrial disease as well. He also made a really good point of, we do want to be thoughtful about every additional anti-seizure medications that you are adding. So depending on the mutation, if there is a mechanism out there in terms of, this is more, we need to target GABA more or target more of the, the excitotoxicity component, you can make some thoughtful decisions about the type of seizure medications that you're picking. And usually if I pick the next one, I pick another mechanism, right? Because there's a reason why you need to add on seizure medications.
It's obviously individualized, but it's not rocket science. If there was a medicine that you added on and it didn't seem to help, that might be one of the ones that you take off first, you know, and usually we wean the medicines down slowly, and then if seizures get worse, maybe you put it back and try a different one. So it's, unfortunately, it's still very trial and error when it comes to anticonvulsants.
But in general, we like the ones that target GABA. And then I have patients when they're on their fourth medication, it's not unreasonable to consider a neuromodulatory device like a VNS as well. If you're working with an epilepsy physician who can talk you through that.
We've certainly had medically refractory patients benefit from addition of ketogenic diet and VNS. So those are good options for our patient population.
Next question, over here in the corner.
Good afternoon. I'm curious to ask the panel where you may see promising opportunities for repurposing existing drugs to treat mitochondrial disease. So here at the conference, I heard a couple examples. I believe one of the accelerator providers was looking at that as a possibility. I heard another example from a doctor about a medication that's under development or may be approved to treat morning sickness in pregnant women that has to do with inhibiting a protein that's produced with mitochondrial distress that can cause symptoms in patients with, say, Pearson syndrome or KSS that could potentially be helpful. That sounded promising to me. I'm just curious, you know, for mitochondrial disease in general, where you see opportunities for repurposing existing drugs that have already been approved.
Yeah, I think there's a lot of promise in that for sure. I heard that accelerator talk too. It was really exciting. There are different platforms to look at repurposing in drugs. There's actually a mechanism through the NIH. I forget which institution. Do you know what you call it? Oh gosh, it's for repurposing of epilepsy medications, or just in general. Anyway, that there's a mechanism through NIH, and I know some people who are going through that. You apply for it. And they actually have a group that will do a lot of the kind of preclinical studies and look at how their panel of approved drugs would work. So that would accelerate a lot of the preclinical and translational aspect of trying to repurpose a drug, you know, towards human application. So there's various avenues for doing that, and I think that's smart because a single drug development can take a really long time. So it could speed up the ability to provide treatment for patients in a much shorter span of time. Plus, there's a lot of safety data on medications that have already been studied, right?
So one of the roads to FDA approval is the definitive clinical trial in these medications. I was talking to a drug developer today who quoted me that they needed to raise $100 to $200 million to run a phase 3 clinical trial, a phase 2, phase 3 clinical trial. That's one of the major impediments besides time, is raising money. Big pharma generally doesn't do this. It's small pharma that starts it off. If the drug looks like it's going to go to market, big pharma may buy it before it goes to market, but money is a big obstacle.
Any other questions? I had a few questions that I skipped over because we were on a roll there. That might have been the next. Oh yeah, that's the next one. Ooh, that's not what I meant to do. What about red light therapy? This question comes up in support groups on a regular basis. Don't know how to answer it. Don't know much about it. But I know that there are claims out there that it improves mitochondrial function. Tell us what you know.
Not very much. Do you know very much? I think our silence tells you we don't know very much.
Okay.
I Probably not one where we can cite a bunch of papers and with clear evidence that it, and it significantly improves outcomes in primary mitochondrial disease. I will say there are a lot of things out there, either in medical literature or things that you see on social media or various news outlets. My general approach is I'm willing to look at anything. Wherever you're reading it, wherever the citation is, I just ask that before you try it, please show it to me so I can review the data for you. But I'm not aware of high rigorous data for right light therapy.
Is that the general consensus of the group? Yep. Well, at least I don't feel badly that I didn't understand and wasn't
I've
able
heard of it. I don't have an update on this concept. Yeah.
Yeah, this concept has been around for 20 years. Red light may make a single mitochondria work better, but in terms of applying that to the absolutely trillions of mitochondria in the body, there's no way to get all that red light in.
All right. I get this question a lot. Is mitochondrial dysfunction treated any differently than mitochondrial disease?
I'm gonna make some assumptions about the question, I think. So there's primary mitochondrial disorders, which we usually think of as being due to a genetic defect in a core gene related to mitochondrial function. And then there's secondary mitochondrial dysfunction that can occur in a variety of other diseases that you might see in Alzheimer's, Parkinson's, ALS, and many other conditions. And so usually it's often unclear in secondary mitochondrial dysfunction whether the mitochondrial dysfunction is causing symptoms and treating that will improve the condition or not. Whereas maybe there's a little bit more of an assumption with primary mitochondrial disease that treating the mitochondria are going to lead to some health benefit. So maybe that's sort of a strategic difference between the two. I'm not 100% sure if I'm interpreting the question correctly, though.
Oh, I think you are. I mean, I'm interpreting it as the question that I get from families other than this person, but it's the person that doesn't have a genetic confirmation where maybe they had a muscle biopsy and it didn't look right, but then they can't find anything, so they've been told that you just have mitochondrial dysfunction or a secondary mitochondrial disease. And do you do anything differently? I mean, should they try the mitococktail? No, yes? What's the typical kind of go-round for that?
You go.
I can share a specific example. So I was following a child who was presumed to have mitochondrial disease, had a lot of multisystemic symptoms, didn't specifically have a telling brain MRI, but findings of myopathy, GI symptoms, developmental delay, making us suspicious for Mito disease. The metabolic labs were certainly off. And then when we did a muscle biopsy, there was an objective complex 1 deficiency, but no genetic answer. The whole exome sequencing, mtDNA sequencing was all negative, including mtDNA on muscle. But eventually, when we did whole genome, we did find a diagnostic answer because the gene or the genetic difference was located intronically, which could not be picked up on the whole exome. And it turned out that they had a different neurogenetic disease, a type of Aicardi-Gouttiere, and while they still see the leukodystrophy clinic and are getting some of those interferon-related therapies, we continue to see them because we know that there is objective complex 1 deficiency with this patient that probably affects them clinically, and they have tolerated the supplements well. They noticed a clinical difference from when the patient was not on the supplements versus on the supplements. We do niacinamide for them, and they continue to be on those. So I think it is to a large extent a case-to-case discussion between the provider and the family.
Oh, that's very helpful, and it's interesting to hear the sort of curved path that you went on to figure that all out. That's a lot. Dr. Cohen, so you're moving forward.
In a similar vein, and again, Dr. Ginsberg can correct me if I'm wrong, but one of the mechanisms of potential mitochondrial injury can occur in muscular dystrophy, where excess calcium is released that actually injures the mitochondria, and it's been suggested that that may be one of the causes of some of the early weakness in muscular dystrophy. So I had a company come around asking me my opinion about trying a therapy that was being investigated in mitochondrial disease for muscular dystrophy. So, that would be, considered a secondary mitochondrial disorder. But we're not, we as a organization weren't getting very far at treating primary mitochondrial diseases, so we needed to form that, concept that we were going to call primary mitochondrial diseases based on genetic abnormalities, and secondary mitochondrial diseases as other secondary injury to the mitochondria. So the answer to the question is we still haven't figured out exactly how to treat primary mitochondrial diseases, and certainly haven't even begun exploring how to treat secondary mitochondrial diseases or mitochondrial dysfunction.
Any other audience questions?
What are your opinions, experience on using IVIG with patients who have mitochondrial disease who don't necessarily have an immunodeficiency for the purposes of like reducing inflammation, which could, improve the functionality of cells?
Probably take that one. So IVIG is pretty nonspecific. I think that has been used on a case-by-case basis by some of us in an acute setting. So particularly if there's a really strong inflammatory response kind of after being exposed to an infection. We haven't studied it, specifically in continuous or maintenance IVIG to control any kind of smoldering neuroinflammation that's going on. The other thing is that that there may be inflammatory mechanisms that is happening, and in some of the genetic interferonopathies, and there's some mitochondrial disease that, may have, dysfunction in the interferon pathway. And IVIG, again, is really nonspecific and may not be directly addressing some of those mechanisms of the inflammation that's actually going on. You asked about Lee syndrome. So Lee syndrome, there's a lot of current preclinical work looking at the interferon pathway and the innate immune system. And IVIG, so it's not the immunoglobulins, but there's other stuff that's in the IVIG that's probably some, anti-cytokine, chemokine that I think sometimes address the neuroinflammatory mechanisms rather than actual immunoglobulins. Too much? Okay.
My own experience has been, it's been used as part of so many other therapeutic modalities in a patient who's very critically ill and who we are not able to, improve quickly. So if the patient does improve, I don't know what role IVIG really played. And then I have other patients who've been on IVIG therapy for a reason unknown, and who we then make a diagnosis of mitochondrial myopathy because they were misdiagnosed as something else before, and it hasn't done any harm. So it was expensive therapy, it hasn't done really any harm to these patients. So that's been my limited experience with these, but it's not prevalently used in my disease.
All right, last question. If we don't have any other, oh, we got one. There she goes.
I'm just curious if there's any type of exercise that seems to be better for patients with mitochondrial diseases, like strength versus cardio versus balance.
So this has been studied by Dr. Mark Tonopolsky, who isn't at the meeting right now. He strongly advises, and again, these are for people who can actually exercise, a combination of cardio and strength exercising. And again, it doesn't have to be a lot. And it could be even doing arm curls with a soup can. But the combination of both works better for mitochondrial disease than one alone.
There is a PDF of that protocol. I just have it on my computer, but it should be accessible somewhere. So it's actually a guide for physical therapy, but there are some pictures in terms of specific exercises that you could start doing. It's actually modified from an exercise protocol used in MS that Dr. Pontarapolsky kind of created with his team.
Last chance for questions, people. Okay, Chris, you had your arm up first. Right here. We can't hear you, Chris.
I'm sorry. You mentioned a protocol for MS patients. Is that available for like public review? Is that a private?
Yeah, I don't know if we could probably work through UMDF. I just have it on my computer,
Yeah,
but I'm sure there's a way we could maybe make it accessible.
Me, I can
yeah,
give it to her.
yeah,
Thank you so much. Thank you.
I know, particularly for you, I think. Yeah.
Making sure there's no hands up. Well, thank you all for joining us and spending this hour and a half together. Thank you to our panelists for offering your time and your expertise. These folks in the audience are so lucky to have doctors like you involved with us.
And I want to thank you for all being here, because you're the road to the cure.